Welcome to the Cooper Surgical Fertility and Genomics Solutions Education and Journal Club series. My name is Jenna Miller. I'm the Clinical Science Liaison for Cooper Surgical, and I will be the moderator for today's Journal Club. Cooper Surgical remains committed to training, education, and knowledge sharing. Over the past weeks and months, we've been offering an online education and scientific program. And this program is intended to help you learn new skills, deepen your knowledge, and engage with our experts and with your peers. So let's introduce the panel for today. We're very lucky to be joined by Dr. Stephen Lindheim and Dr. Jody Madeira for today's Journal Club. Dr. Lindheim is a professor of Obstetrics and Gynecology at Wright State University, Boonshoft School of Medicine in Dayton, Ohio. He serves as the medical director of the Santa Monica Fertility Center in Miami, Florida. He graduated from Temple School of Medicine and was a resident at Pennsylvania Hospital in Philadelphia. Dr. Lindheim completed a fellowship in reproductive endocrinology and infertility at the University of Southern California. He also completed a master's degree in medical management from Tulane University School of Public Health and Tropical Medicine. And he is currently board certified in both OBGYN and REI. He currently serves on the board of directors for ASRM and is the current president for the Society of Reproductive Surgeons. Dr. Lindheim has a major interest in vitro fertilization, oocyte donation, embryo donation, as well as surrogacy. He is a well-recognized expert in the field of minimally invasive reproductive surgery, and he has over 200 scientific publications and book chapters. He's also an associate editor for Fertility and Sterility. His research focuses upon embryo implantation, minimally invasive surgery, and polycystic ovarian syndrome. He is well known for his empathic approach to patient care. I love that. And he also includes patients who are traveling from abroad to seek treatment, which his peers have acknowledged with awards, including top doctors. So that's Dr. Lindheim. As for Dr. Jody Madeira, she is a professor of law at the Lewis F. Niezer faculty, and she's also a fellow at the Indiana University Maurer School of Law in Bloomington, Indiana, where she co-directs the Center of Law, Culture, and Society and serves as bioethics liaison for the Indiana Clinical and Translational Sciences Institute. She is an expert on qualitative and mixed methods research, and her research focuses on the intersection of law, communication, and medicine. She prioritizes assisted reproductive technology, bioethics, substance use, and firearm violence in her research. She is the author of Taking Baby Steps, How Patients and Fertility Clinics Collaborate in Conception, and Killing McVeigh, The Death Penalty and the Myth of Closure. After personally experiencing unexplained infertility, Jody shifted her research to focus on emotions and treatment decision-making in reproductive medicine. Her current research assesses the experience and it currently addresses experience and safety. Her research has appeared in leading legal and peer-reviewed publications such as Fertility and Sterility. Dr. Madeira holds a PhD from the Annenberg School for Communication at the University of Pennsylvania, as well as a Juris Doctorate from the University of Pennsylvania and a Master's of Science in Sociolinguistics from Georgetown. We're also happy to welcome back Jeff Isner, who is the co-founder and CEO of EngagedMD, which we'll be discussing today. Jeff joined us a couple days ago for our webinar, and so we're really glad to have him back. Over his leadership over the past 6 years, EngagedMD has grown to serve over 100 fertility clinics across the US, the UK, and Canada. Today, Jeff will be sharing tangible takeaways for interacting with fertility patients in a post-COVID world. That's some of the things that he'll be addressing in the Q&A session. As for myself, coming from a background in virtual genetic counseling, I'm pleased to be participating as well as the moderator. And with that, I will turn it over to our panelists.
Hey, thank you very much. I'm not embarrassed with that introduction, but thank you very much. It's been a pleasure working with Jody and us now today to present an accumulation of some of our work. This topic is called Informed Consent, Terminating the Paper Trail. I think that Jody and my paths were just meant to be, because a lot of her interactions with patients, her commitment and passion towards that sort of was magnetic to me. And it just was a great relationship to use this multimedia platform. And it just seemed to work into a number of publications and work together. So it's been nothing but a pleasure working with her. And we are delighted to be here today to discuss this topic. These are our disclosures. And with that, today, we're going to be talking primarily publication using the EngagedMD multimedia platform with publication in Fertility Sterility in 2018. Also highlighting somewhat on a paper, Informed Consent, More Than Just Sign Here, that is just coming out in press, and excited to be presenting at the virtual ASRM meeting some of our abstract preliminary data. After this presentation, we hope that you'll be able to take away some basic history of informed consent and grounding in bioethics principles, traditional process of obtaining informed consent, and with respect to ART, how patients experience the informed consent process and their attitudes and perceptions. And lastly, the potential benefits of multimedia consent aids. There are thousands upon thousands of babies born as a result of this fabulous technique called ART, assisted reproductive technology. But with that, we all know that we have the potential for some really bad complications, as evidenced with this picture here of Octomom. And now with the ever-expanding technology that have posed a number of complicating issues in terms of talking to our patients regarding pre-implantation genetic testing and results including mosaicism, should we transfer, not transfer? And the questions that come up is that, are we adequately telling patients all the information that we can? And thus some people would say that we're really fraudulent in posing or not posing all the information appropriately. How did we get here in terms of disclosing information? If we go all the way back to ancient Greece, where we discussed only shield and concealed, moving into the 14th century where we overpromised and rejected defiance, and by the 18th century, we're educating without consent, and by the 19th century, we did ethics but without consent. It wasn't until the 20th century that case law began to define informed consent, starting in 1914, working its way all the way through 1980s, where we transformed physician-centered care to now what we know as patient-centered care, and some would even say informed refusal. In the 20th century, informed consent is now a necessary process to obtain patient permission and enhance patient understanding prior to healthcare interventions. And as we know, in 1978, Belmont Report had identified core principles of beneficence, non-malfeasance, justice, and patient autonomy. And with these, we are responsible for promoting the well-being of others, to do no harm to others, distribute resources fairly and equitably, and just as important, respect the individual's rights and opinions. But with patient autonomy, while the patients have the right to make their own healthcare decisions, they can only exercise this right with full information and proper understanding. Informed decision requires education, knowledge, counseling on evidence-based choices that are available, and discussing the risks and benefits of each choice. And we need to employ good communication skills and counsel patients about the evidence and rationale for using or not using a given intervention. These principles, while initially developed for research with human subjects, have since been applied to clinical medicine and are essential as the foundation for the informed consent process. Through informed consent, patients' needs are appropriately discussed, including balancing of risks, benefits, and alternatives, ensuring the legal obligations, and improving patients' rights and autonomy. Now, while patients have the right to make their own healthcare decisions, they can only exercise this right with full information and proper understanding. But the question that has been raised is, are we really employing good communication skills and counsel to patients about the evidence and rationale for using or not using a given intervention? Unfortunately, there's a paucity of data on how patients experience the informed consent process. Studies suggest that many patients view informed consent as merely an obstacle to overcoming prior to beginning treatment, and that there's impaired patient recall and comprehension and a failure to even read. If we look at the gastroenterology literature, recall is a major obstacle to overcome in order to proceed forward with medical therapy. 92% of patients in this one study reported that patients did not recall key details about their polyps required to establish appropriate screening and surveillance intervals. This suggests that new tools are needed to ensure patients' understanding is very, very important about their findings, and that we needed to improve recall accuracy. Now, informed consent within the context of assisted reproductive technology poses unique ethical, medical, legal opportunities and challenges, since ART is more of an elective treatment than one needed to resolve a medical emergency. ART's risks, benefits, side effects, and alternatives often bear little resemblance to other practice areas, including risk to people other than those consenting, that is, resulting children, legal consequences involving establishing and relinquishing parental rights, third-party reproduction, posthumous procreative planning, gametes or embryo disposition after dissolution of a relationship, and of course, multiple treatment options. Furthermore, the complexity of our technology continues to evolve and is overwhelming. It's overwhelming to us as providers, let alone the patients. Look at pre-implantation genetic testing, and now even trying to describe what mosaicism is, let alone having the patients having to make very, very important decisions about having embryo transfers or not. Unfortunately, we as endocrinologists, reproductive endocrinologists, mental health professionals, and reproductive health attorneys such as Jody have expressed concern over whether patients actually understand, whether they can properly balance the risks and benefits and side effects and alternatives, and that do patients find these consent processes overwhelming, undermining recall and comprehension. And the informed consent documents continue to evolve to include more complex services and issues. And as a result, we as providers have strategically tried to simplify these documents. Given informed consent's complexity and length, ASRM, American Society of Reproductive Medicine, has created a model template, but unfortunately there are no universal ART informed consent requirements. Empirically, there is very little research on ART consent forms, and the existing research consists of theoretical scholarship on consent in the context of third-party reproduction and embryo disposition. For example, difficulty of considering tragic circumstances such as death or divorce, difficulty in making disposition decisions, and patients changing disposition preferences. Many patients can't even remember giving consent for storing their embryos, nor recall the provisions from which they consented or what the forms actually look like. The empiric themes that have resulted include the focuses on the physician providing information rather than ensuring patient understanding. the document's format and poor drafting, the use of technical jargon, and patients overwhelmingly state that are overwhelmed with all the paperwork and the information.
And in fact, to gain additional insight, we performed a study that is now in press where we discussed a quantitative 197 question online survey-based study with 262 participants who had undergone IVF in the past 5 years. The survey was disseminated through a variety of online platforms. Here, you'll see that 87% read the informed consent documents. Of note, only 10% read the patients not carefully, and 21% read them with average attention. Therefore, 2/3 of patients read their documents somewhat or very carefully. In addition, using a Likert scale from very easy to very confusing, 21% of patients felt their documents were confusing or of average comprehensibility. Again, this means that 3/4 of patients reported that their documents were of above average comprehensibility. Moreover, 5% of patients felt that these forms were too long, 30% felt that they were unhelpful, and 18% found them overwhelming. When it came to conversations with medical treatment team members, 82% of patients remembered such discussions, but only 59% remembered discussions of informed consent forms. Topics that were most frequently discussed included the likelihood of multiples and associated risks and complications of multiple births. And in fact, only 50% reported discussing selective reduction, which was more likely to be discussed when patients were under 35 years of age. Now, clearly, there are study limitations, including that participants self-selected, lack of racial diversity in respondents, which is also typically true of the IVF population in general, and an unvalidated patient survey. But the study did identify several important factors that undermine the efficacy of the informed consent process, other than recall and comprehension, and it does raise the need to assess other aspects of informed consent. Now, in other publications, we have raised additional important questions, such as the need to assess whether medical and legal safeguards of informed consent are adequately balanced with comprehensibility, thoroughness, and patient engagement, as well as how can we reform informed consent procedures beyond just revising documentation to improve patients' understandings and experiences.
With that said, there are constraints to reform. Education continues to get more complex, and patients expect and deserve a very high-touch experience. On top of that, there are very highly motivated patients who come into the office going to Dr. Google, having tons of information, and with this massive pressure on us, the medical staff, we have to shorten time spent with each patient and see more patients. We all know about healthcare value, which is quality over cost. And in order to reduce costs, we try to become more efficient, but then it would be argued, are we compromising quality at the expense of efficiency, undermining our patient value? So what are the solutions? In other disciplines, medical practitioners have employed a variety of multimedia, patient education, and consent tools to improve patient comprehension, ranging from DVDs, narrated computer applications, computer tutorial complete with quizzes. These multimedia aids ensure consistency across providers and patients. They decrease the feeling that consent is a bureaucratic routine, while simultaneously encouraging patients to be more involved with their care. Some of the older studies have yielded equivocal results, however, regarding their superiority to traditional paper consents. It's thought to be due to the poorly designed aids that could negatively impact the patient education. More recent randomized studies have linked multimedia interventions to greater comprehension and recall, patient enjoyment, improved knowledge, relationship, physician and patient, faster learning, and lower anxiety. So in summarizing some of these various solutions, in-person educational classes are great, but they require human resources and physical travel. ASRM standardized consents are great, but they're complex and cumbersome, and patients don't want to read. And sending out content via DVDs and websites are great, but there's no feedback loop. and thus, which brings us here today, the inception of EngagedMD. EngagedMD, briefly, is a multimedia platform through which patients can watch customizable educational video modules about IVF, ovulation induction, IUI, and other aspects of fertility treatment. The staff assigns patient educational modules from a multimedia library based on treatment needs. These modules consist of video sections outlining all aspects of treatment. The patient and partner can access these videos whenever they desire via a secure portal. After each section, patients answer comprehension questions, that is, the patient and partner, that reinforce key concepts from the videos. These interactions are digitally documented, and we can see real-time the results and identify areas where we can focus additional education. These modules have been created and reviewed by experts in our field of reproductive health, and they're designed to increase understanding and retention. It's not meant to supplant, but rather supplement in-person consultation with these comprehensive videos to educate patients and their partners on treatment options, risks, and benefits. On top of that, there's an e-signature. Each signer, meaning the patient and or partner, receives and signs documents through a HIPAA-compliant secure email. It can be integrated with any EMR system. The staff can view the progress of signatures and keep track of all the signatures. On top of this, not only are there over 100 clinics in the United States using EngagedMD now, this multimedia platform, but it's also being implemented internationally, where now it's being translated into other languages, including Japanese, where they've begun to implement this in their ART process. The question is, what's the efficacy? And we're all about science. So this is where the study using the EngagedMD multimedia platform, we wanted to evaluate patient and provider feedback on how this multimedia platform helps in understanding the risks and consequences of IVF and IUI treatment and impacts the informed consent process. From October 2015 to March 2017, 6,500 study subjects and 120 providers were recruited from 14 clinics that had implemented this platform. In total, we analyzed almost 3,100 patient and partners who have completed 5 key questions, which we'll review in a second, and 41 or 34% of providers who had responded to a survey were included in the analysis. We wanted to assure consistency, and therefore these key questions try to answer the following. Did this multimedia platform answer any questions that they otherwise would have had to ask the medical team? Did you like using the multimedia platform? Did you feel that the educational videos were a helpful addition to your consultations? How important were you properly educated? And how did it make you feel going through the process? Of the almost 3,100 participants, 66 did IVF modules and 34% did OI, IUI treatment modules. In general, 99% of the respondents felt that being properly informed of their care was either important or very important. Now, this is a complex slide, and let me go through it with you slowly, is that 93% said that it was intuitive to use. 90% said it was appropriate length. 95% said it was appropriate level of detail. And 89% said they were comprehensive questions that reinforced key concepts. 83% said it improved satisfaction with care. 77% they were more comfortable with pursuing treatment. 86% said it better prepared them to sign their consents. And almost 50% said that it answered many questions that not only would they otherwise would have asked, but just as important, may have been afraid to have asked. And 97% said that it was a helpful addition to their consultation. Now, this is very, very important, as I mentioned, that it does not supplant, it supplements effective information sources. And 55% still said that their physician is the most effective information source. So this is meant to be supplemental, but the multimedia platform was significantly better than website, nurse training, and printed materials that we give our patients. From the provider's perspective, 68% said it saves up to 1 hour per patient. That's a significant impact on healthcare value. And 63% said they felt that it improved patient learning, understanding, and made patients accountable. The strengths of this study is that it was the first to empirically assess a multimedia intervention in ART-informed consent process and to analyze it both in patients and from both patient and provider perspectives. It was anonymous, which enhanced the truthfulness, and it had a national distribution, which helped achieve a wide geographic distribution of patient values, attitudes, and experiences. Clearly, there were limitations. There was inability to control for patient experiences due to they could have gone through previous prior treatments, a lack of uniform implementation of the multimedia platform. There was no baseline assessment to assess for patient knowledge. Demographics were not obtained, and the survey did not assess how many had completed the survey and underwent treatment versus those that didn't, which may have impacted outcomes. But what it did tell us is that it suggests that this multimedia platform improves patient education regarding ART treatment. They have more control over their medical decision-making process, and it better prepares them to participate in the consent processes. It is well-liked by providers and nurses and very easy to implement. But with that said, we always take a step back and we say, okay, well, it's a descriptive study. Now we need a randomized clinical trial. And I want to thank my colleague, Dr. Lene Goodman, who has worked in conjunction with Dr. Madeira and myself, because what we did is we asked the questions in a randomized fashion, trying to assess the impact on patient comprehension and recall, emotional dynamics, relationship, and potentially the ideal time for implementation. And in asking this question, we designed a randomized clinical trial that is still preliminary in its results, and we're proud to say that we've received a presentation for this year's virtual conference presentation. And we looked at patient relations, comprehension, the e-consent process, and the emotional well-being of patients during fertility treatment. To date, 77 women have been enrolled, 35 for IUI cycles, 42 for IVF, and 55 have completed to date. And just a small smattering of the outcomes in just a second, but the groups were either randomized to conventional treatment with standard counseling with the doctor and the nurse team, or the multimedia platform with, in addition to the standard counseling, they had the addition of the online multimedia platform. And again, just a taste of, I keep jumping ahead of myself. The assessments that we did in this trial were looking at fertility knowledge, meaning we gave them, we didn't call it an exam, but we called it a fertility knowledge assessment of 15 questions that were evaluated at time point 1, defined as the start of treatment, and time point 2 at the conclusion of treatment. We looked at a therapeutic index that looked at how much patients agreed or disagreed with statements regarding the physician and nursing team. And we looked at a modified state trait anxiety inventory, or a STAY questionnaire, which was 19 questions. This is a weighted score of 1 to 4, with a possible score from 19 to 76, with a 50th percentile at 34 defining an anxious woman. That was done prior to treatment, prior to start of the treatment cycle, after their teaching session, and at the conclusion of their treatment cycle. And again, just a small little taste of the results shows that compared to baseline, overall, the average scores of those that received the EngagedMD or the multimedia group were significantly higher than the conventional group at the start of therapy. But while higher, it was not significant after treatment. But when considered with respect to the type of treatment, those that got the the multimedia platform scored higher at the start of treatment in both IUI and IVF cycles, but at the conclusion of the cycle, IVF knowledge scores were significantly higher in the EMD or multimedia group. With regards to therapeutic index, the scores were overall very high for both groups, but they didn't differ between the multimedia or conventional groups. But those that assigned, those that signed the online consents, almost 93% felt that they preferred this over standard paper consents. And with respect to anxiety levels, this was a very interesting finding, is that anxiety levels were significantly elevated in first-time IVF patients and after treatment compared to those undergoing IUI. So if you can see, it was higher prior to teaching, but it remained significantly elevated after teaching and at the conclusion of treatment. With respect to physicians, all surveyed could not determine a difference in the fertility comprehension between groups. However, all the nurses reported an improvement in comprehension, shorter teaching visits, and fewer questions in the multimedia group. So the conclusion, our preliminary conclusion, is that the results suggest that having access to this multimedia platform improves patients' understanding of their diagnosis and treatment prior to undergoing fertility therapy. Patients and providers using the online consent process agreed that it is a valuable addition to streamline the consent process. And overall, anxiety levels in this cohort of IVF patients was high, indicating that added psychological resources may be beneficial to this population. So, an overall summary is that informed consent is a necessary process to obtain patient permission and enhance patient understanding prior to healthcare interventions. Informed consent should include core elements of beneficence, non-malfeasance, justice, and patient autonomy. And what we all recognize is that informed consent in ART presents unique ethical challenges and considerations for patients, partners, and providers. Multimedia platforms may represent an opportunity to improve delivery of information to accommodate many different learning styles, increase patient comprehension, comfort, and communication with providers, ensuring accurate information is delivered in a standardized format, and has the potential for an informed consent process that is more efficient. Now, while we know with respect to autonomy, patients have the right to make their own healthcare decisions, but they can only exercise this right with full information and proper understanding. And in order for us to do that, we need to employ good communication skills and counsel our patients. Informed decision requires education, knowledge, counseling, and discussion. As the process of future directions is that as the process of informed consent evolves, future research needs to evaluate its impact upon emotional dynamics and the best implementation timing for such multimedia platforms. And so with that, we will now open it up for discussion and dialogue.
Thank you so much, Dr. Madeira and Dr. Lindheim. That was so interesting. I've heard of these, I've been familiar with the EngagedMD platform before, but it's really interesting to see the actual research of how this tool is being perceived by patients and what providers' thoughts are about it as well. So with that, and to the audience, please submit your questions at any time. One question we have from the audience is, can anyone on here suggest a few sites where we can find, where clinicians can find templates for ART consents?
Yes. So the ASRM website actually has model-informed consent forms for a variety of procedures, and that's generally the starting point. They're both of these forms actually are approved by committees, including ethical committees and practice committees.
Yeah, I think it's a wonderful starting point, and definitely the standard. I think every practice that utilizes them puts their own spin on it to some extent, makes certain that it applies to their particular clinical setting.
And I would
go ahead.
I would also say that using ASRM's template and tweaking it to your own practice, I would be happy to share my consents with anybody who would like to use them.
Oh, that's very nice.
Access to them, which we've shared before.
I just saw just this week, ASRM released a new committee opinion about mosaic results for embryos. And I know that the supplemental material from that particular document did include a consenting template, which I know a lot of people in the field have been asking for. So that's just something that I heard recently that ASRM is newly providing. And Jeff, along those same lines, so if someone is using the EngagedMD platform for consenting, they can customize the consents to whatever documents they want to use.
Yep, that's correct. We actually enforce that we use the practice's consents. We don't like to provide boilerplate consents because we don't think that's the right approach. We take anything that you're doing on paper and digitize it according to the practice's needs. That
makes sense. Here's another question from the audience. This audience member says it's fascinating that doctors didn't see EngagedMD improving patient education, but nurses did. Can you comment further on why that might be the case?
I think that actually might be the case because doctors might be more removed from the informed consent process. Traditionally, nurses are on the front lines, not in every clinic, of course, and that varies with practice to practice and even state law to state law. Pennsylvania, for example, requires physicians to actually conduct the informed consent discussion itself. But I do think that nurses generally see the most time saved from EngagedMD prior to the consultation.
The physicians may also have their standard spiel and not have a sense of what the patients already know. This platform is great because you can see areas of weakness where patients may have answered their questions wrong as they're doing the modules. And I think that in a larger sample size, the physicians may actually identify or see or appreciate that it's great because now they can focus their discussion instead of sort of doing this standard spiel or their personal template in which they present to patients.
I know as a genetic counselor that seems like it would be very helpful to me to know what things the patient isn't as clear on just going into that conversation. I feel like that would make that conversation so much more fruitful.
Yeah, I think it's important to keep in mind the size of the study, and it was a single site. So different workflows and different implementations will have different results. So not being fully aware of exactly when the EngagedMD intervention was put in place for this particular study, I think it really, as a rule of thumb, we always recommend earlier on, but I can see an instance where it's introduced after a physician interaction and then the nurses are taking on the rest of the education and consenting process. So I think this really does depend on when you introduce a platform like this and can really significantly impact the results that the different types of members at a clinic can perceive.
Yeah, so you can implement this right after your initial consult if you think the patient's going to be doing an IUI treatment or if you know they're going to be doing IVF, or perhaps you wait later until they commit to doing a certain type of treatment and then you implement it. Or you may say before you come to your educational session, your treatment and in-service, whatever everybody calls it, you implement it there. So there's various time points that you can capture this, using this platform. And I think we don't know when it is optimal. It would make sense the earlier you give it, the more patients would appreciate it or have knowledge on it. But again, it's not standardized for every practice.
Sure. So this can be to Jeff, or if either of you are involved in future research, please pop in. How is EngagedMD addressing these findings? Do you have any future plans for other research avenues or possibly updates?
Yeah, so first of all, I just want to thank Dr. Lindheim and thank Dr. Madeira for putting, and all of the other researchers who've been involved with the various projects that have been taken on in terms of getting data behind what's actually happening inside of the clinics. I think that's what makes us better. That's what we can do to constantly improve ourselves. And we're always trying to release new features, release new modules, so that we can be scientifically better and really push the field forward. So anybody who's interested in doing more research, please reach out. We're more than happy to support that. A few things that we've done since the study started, we've actually adjusted our modules and really reinvented them. One thing that really stuck out to me is just the level of anxiety. And when we originally introduced our modules, it was all about education by any means. So make sure that all of the right things are out there, all of the right risks are out there. And I don't think we had as much focus on how the patient would actually receive it, other than the fact that they got the information itself. And the anxiety levels are extremely high across the board. And we're trying to address other ways through the platform itself, and as well as in the tone of the modules that we take and the content that surrounds the true informed consent part, to provide a little bit more context to the overall care, provide some a more calm tone than just the hard risks.
If I could just chime in and say that this, I tried doing a multimedia platform 5 years ago, and somehow Jody, someone had said to me that there's another platform that's out there. You should take a look at it. And of course, my grant support of $20,000 versus their much bigger, more elegant platform sort of connected us together. And the thing that I marveled the most was your commitment. As I had said to you, you need to have some science behind this. And I appreciate that you've done that. And I think that we've shown. I think the most interesting finding, I wasn't surprised about knowledge. I was very surprised about anxiety, which we really need to, make sure if we have access to, our social workers and support with regards to that, and a better evaluation of the effectiveness for, efficiency and healthcare value that what this provides to us. Because Jody and I have had a discussion on this back in the early 1990s when I started in practice. We all had said, wouldn't this be great if we could have a full-time person that all they did was do informed consent? And because it's just ballooned ever since then. And this, is very expensive to have a full-time person doing informed consent. So now to have this module in a computerized person-like type thing has really transformed the ability to provide better informed consent. We're still not there, but better informed consent.
Yeah, I think it would be arrogant to say that we got it perfectly right away. This is a novel approach, and we're really trying to push the field forward, like I said. So the more we can put science behind it, the more statistics and data that we have to drive this idea of how we can do informed consent differently forward.
Absolutely.
I agree. And actually that picks upon the question that someone just posted in the chat, which is, the link with perhaps decreases or increases in risks of legal action based when things do go wrong. And I think this does go to the fact that there's really no such thing as perfect informed consent. You always have to balance factors like anxiety versus you don't want patients to be too overwhelmed by their emotions, but at the same time, they do have to feel some anxiety to really fully appreciate a risk. They have to put themselves forward. If I decide this and, this happens, how am I going to feel, for example? And so I think there's that need for an imaginative engagement, and the provider can really facilitate that, but also so can a multimedia informed consent platform that allows patients to extend themselves into a situation that they've never been in if they've never undergone IUI or IVF. And so, again, and this just underscores the fact that this informed consent is a process. I do think if it is used appropriately, fertility clinics can mitigate their risks of patients taking legal action, because redundancy is very important. The more times you get important information out there and the more formats in which people see it, the more patients will say, yes, I did actually understand that. I was told that. And then, of course, that allows practices to say, even before they came from the consultation, even before we discussed this, they watch these videos, and if they are sued, they can provide these videos to the court just as like they would provide an informed consent document.
That's a great point. One of the values of this platform is that before a patient signs a consent, you have the ability that they have to watch the video before they sign the consent. You don't have to have them do that, but it's a unique option within the program. So it's a great point, Jody. I'm glad you raised that.
Yeah, so am I. Since I don't know if you saw, Jody, but someone posed that question from the audience. Is it do you think EngagedMD helps fertility clinics mitigate the risk of patients taking legal action? So I think you already answered. And similar things, this is such a great discussion, and it's really got my wheels turning on a number of things. Dr. Lindheim, you mentioned that during your presentation and just recently with some of your comments that there's some evidence here that added psychological resources may be beneficial for patients. Do you think that such resources could be delivered via a multimedia platform like this?
Well, I mean, as we're moving into the world of teleconferencing with COVID, I don't see why we couldn't. If we somehow, brought together the mental health care providers and sought how we could, do stress reduction, then maybe we would see differences in this. I think the one important slide is that it's not to supplant, it's meant to supplement. And I think the same thing would occur with that. I don't think you can ever say that we would never need support. I think it should always be offered, but I could not see why it wouldn't improve it. So I think there's another great thing for Jeff to begin to work on.
And I think just as a starting point, just awareness around the psychological resources is so important. Patients don't even know what's available to them. There's oftentimes a lot of help from how you approach fertility treatment from a psychological aspect at your clinic, and not even knowing is the place to begin. You've got to be aware of all the different resources that are at your fingertips. So I think that's a great place for us to start.
I like that.
And just jumping in real quick, patients sometimes have to be given permission that it's okay to seek, mental health treatment, or okay to have a conversation, okay to admit that they have questions about how they're feeling. And I think, again, it's one thing where their doctor could tell them this, but they may not want their doctor to know about it. They might not want they might feel that it would imperil their cycle. And I think, having this information through a neutral platform, could encourage them to take that step. And the second is that there's been great strides in providing telehealth, counseling, actually, in many fields over COVID-19. So I think that just demonstrates that this is an efficacious alternative.
I think that even considering, I'm just throwing out an idea to Jeff, is to take this modified stay anxiety score and implement it, as you're talking about mental health, well-being, or just well-being going through an ART cycle, and, use this tool to evaluate patients' and partners' stress levels. And if there's an identifier, maybe the practice can, see, this patient is more stressed out, and maybe push them to, mental health, resources. That may be a useful way. And I know we're talking candidly here. I can certainly help you find those resources to help, mental health providers to help navigate this for you.
Yeah, I love that idea. And going back to something that Dr. Madeira said, it's more than just introducing, it's normalizing, it's making it acceptable, making it feel comfortable, and just showing patients that this is okay, and it's okay to ask for help, and we're here to help you.
Going back to some future avenues, I wanted to repose a question to all of you that we got a couple days ago on one of our webinars, which was, is there any, or could there be any studies looking at the use of EngagedMD or multimedia platforms with actual clinical outcomes? Any thoughts on that, Jeff or Dr. Madeira or Lindheim?
Yeah, I'd actually like to defer to Dr. Lindheim as he's implementing EngagedMD and what his thoughts are on how we could impact clinical outcomes.
And you know what? I'm going to ask you to repeat the question because I saw another interesting question come in. So I was. Can you repeat the question again?
The question is, for future research avenues, could you consider looking at EngagedMD and clinical outcomes?
Well, there's always the question of, the answer is yes, because we could look at compliance, right? So the more information patients have about how to comply, the greater their compliance will be. And if they're told that they need to comply instead of doing what Dr. Google says, I think that will just increase rates of compliance right there. Again, and this goes back to the anxiety, patients can't comply in future cycles if they never go for those future cycles in the first place. And if we encourage them, normalize seeking mental health that's appropriate for those who need it, again, it keeps them in the treatment population.
Yeah, it's a hard one to ask patients to be honest if they messed up dosing, for example. That's not an articulate way of saying that, but we have data, although we've never published on it, that up to 20% of IVF and third-party reproduction patients have been either non-compliant or forgot, took the wrong dosing of medications. Many of them have still gotten pregnant, but we don't know, how that potentially could impact outcomes. And I think, Jody's right that, it's certainly worth looking at. And if there was some way to massage this into the program, we could certainly look at clinical outcomes. It's a great idea.
Yeah. Another question from the audience. Do you have any data on how much time clinics spend on informed consenting with versus without EngagedMD?
Well, the answer is no. And that's, we can certainly go back and see if we can identify any of that information. The paper that Jody presented is really telltale to me, is that less than 60% of patients recall having any type of discussion about their informed consent. We're not talking about the IVF ART process, but that means over 40% of patients did not have dedicated sit-down time to have discussion of informed consent. So let alone talking about it, it would be certainly interesting to find out how much time clinics did or didn't spend. But the one thing from the descriptive study is that physicians felt that they saved an hour worth of time. And we just all know that even if you take a mouse and your mouse isn't working, just that minute, saving a minute here, saving a minute there, let alone saving an hour of time is enormous.
Yeah, it's a very challenging task to your point, Dr. Lindheim, how you can precisely measure exactly how much time at a clinic. But we do have a lot of anecdotal data after installing at over 100 clinics, and we work very closely as we install to understand existing workflows and where practices are hoping to optimize and save time. And it's very typical to take an entire 60-minute appointment and get rid of it. And it's also very typical to reduce multi-hour teach classes down to 30 minutes. So as a rule of thumb, we see 1 to 2 hours saved of just in-person clinical time that you're able to utilize the tool to supplement what's going on when you actually are in person to person.
And as it showed in the data, the physician was still the primary source of information. So there's still that touch point. There's still that interpersonal relationship there. It's just a little more efficient when it happens. All right, last question. We have to wrap up, but this is so interesting. I wish we could keep going. I just want to pose a general question to all of you, which which is informed consent and non-directive patient care, is that truly possible with or without these sorts of platforms?
I don't think humans are ever perfect at anything, especially when there's so many potential experiences with ART. And as with everything else in life, you may have to be through something to actually understand it. However, but that's everything in life, right? So you don't know about the experience of skydiving until you actually skydive. But if you have a discussion beforehand, you're going to leap off with more trust and more understanding and a knowledge of what to do if things go wrong. And again, that's going to mitigate the anxiety. And so I think as perfect as it's going to be, we're going to get there by realizing that informed consent is a process. And you're going to have this initial need for an informational exchange, but a continuing need for education and a continuing need for dialogue.
I would just add in that the sad part is that we make an assumption that with each ART cycle that it's its own independent event and that we should be consenting the patients each and every time. But what we do is we find that we are shortcutting and circumventing the important component of informed consent each and every time as it's its own random event. And so therefore, I don't think it's ever possible. And do we make patients do the EngagedMD platform? Do we hire that full-time provider to do informed consent? It's never going to be perfect. Jody, you said it eloquently. Thank you.
I think we have to strive for perfection and recognize that forward progress is getting us closer, recognizing also that we may never have 100% perfect informed consent. That may not be a possible thing, but taking steps forward is the right approach.
I would have to say I agree with all of that. I think informed consent is the goal. But it's something that's very complex, as we've discussed today. Obviously, it's a very complex topic, and therefore it's very difficult to get perfect informed consent. But as Jeff likes to say, I've learned in this last week, don't let perfect be the enemy of good or great. So I guess with that, we'll have to close the Q&A session. Again, this has been a really great discussion, so I'm sad we can't just keep talking for another hour. But thank you so much to Dr. Madeira, Dr. Lindheim. Thank you, Jeff, as well, for joining us. And thank you to everyone who's attended this webinar. Some really interesting topics were addressed. Thank you for submitting your questions.